we might have a few more people coming in, but we do like starting right on time. So it is 12:01, and I'm Dr. Megan Aston, the director of the Center for Transformative Nursing and Health Research, and Julie, who just turned her camera off. Julie Berry is our research manager, and we are thrilled to have Dr. Oladayo Afolabi here with us today, and we have the full session for you to give your presentation and tell us everything we need to know about palliative care and clinical network Nova Scotia from Nova Scotia Health. And I'm going to turn it over to you. So thanks so much.
Thank you very much, Dr. Aston. Sorry. Yeah. So thank you for having me here today. My name is Dayo Afolabi, and I want to thank Professor Marilyn McDonald and Dr. Ellen Moody, who really highlighted the opportunity to be able to present some of my past research to the team here today. So my background is in nursing in Nigeria and the UK. I have a master's in health planning and management and an MSc in mental health, and a PhD in nursing with a specific focus on palliative care from King's College London. And I've been working for the past month now with the Palliative Care Network with Nova Scotia Health. And we, as a palliative care network, deal with everything around palliative care, specialist palliative care provision, just sort of supporting performance and quality provincially. Some of my colleagues are here with us today as well. So I'll be presenting on some work from my PhD, which is development and feasibility testing of a complex intervention to deliver palliative care for patients with serious illnesses within primary health care. So we know that 50 million people, more than 80% of people experiencing serious health-related suffering live in low and middle-income countries, where access to basic palliative care and medicine-based pain relief is extremely limited or non-existent in some cases. And there has been forecast by researchers that by 2060, an estimated 48 million people, or 47% of deaths globally, will die with a serious health-related suffering. And that represents about 87% increase from the number in 2016 in low and middle income countries. And we know that there is inadequate integration of palliative care into health systems, and this contributes to the inequitable experience of serious health-related suffering in low and middle income countries. So we also know from data from the WHO that over the next 4 decades, non-communicable diseases are going to increase rapidly in Africa. For example, cancer is going to increase by 43%. COPD is going to increase by about 255%. So kidney diseases, cardiovascular diseases, and cerebrovascular accidents, and also HIV/AIDS mortality is going to reduce by about 58% over the next 4 decades. So the current focus of palliative care in Africa has been on HIV/AIDS and cancer. So there's a need to broaden the base of palliative care delivery to be able to focus on these emerging trends. So based on that, in Nigeria, we have about 17 facilities that provide palliative care services, about 200 million people, and these facilities are located in tertiary healthcare facilities majorly. And also we currently rank category 3A, which means isolated palliative care provision within the global atlas for palliative care developed by the World Hospice and Palliative Care Alliance. Also, in terms of policy, there's a national strategic policy for palliative care that was developed in 2021 during the course of this project. But prior to this project, we only had palliative care mentioned within the cancer policy and the HIV policy. In terms of medicine availability, there is still poor access to medicines. And also, in terms of education, there is poor integration of palliative care within pre-service education for healthcare providers. For our healthcare structures, about 95.5% of healthcare facilities in Nigeria are primary healthcare facilities. Secondary facilities are 4.2%, and tertiary facilities only represent about 0.3% of facilities in Nigeria. Nevertheless, all the palliative care provision that we currently have in many areas of Nigeria are based within the tertiary healthcare facilities. So this sort of gave us the first idea on the need to improve palliative care and how to increase access to palliative care. And in order to do that, we looked at international policy direction around palliative care. We know that the strategic direction of different policies has been to integrate palliative care within primary health care. From the goal 3 of the Sustainable Development Goals, which emphasizes universal health coverage and recognizes palliative care as one of the essential elements within primary health care that must be delivered to be able to achieve universal health coverage. We also know that the World Health Assembly in 2016 asserted that palliative care is a function which must be delivered within primary health care. And this sort of corroborates the declaration at Astana in 2018 as well around palliative care delivery within primary health care, and improved upon the Alma Ata Declaration on primary health care. We also looked at the African Palliative Care Association strategic plan, which aims to ensure that palliative care is integrated at all levels of the healthcare system. So we know we need to provide primary health care, palliative care within primary health care, and we know primary health care is the foundation for healthcare systems. But how do we then do that is one of the big questions that we asked ourselves. So we looked at the guidance from the WHO. In 2018, they released the guidance on integrating palliative care within primary health care. And within that guidance, it assumed that there is a functional primary healthcare system in low and middle income countries, but acknowledges that the primary healthcare system may be underdeveloped. But yet it failed to address the integration problems that these underdeveloped primary healthcare systems like Nigeria's may face in delivering palliative care within primary healthcare. The guideline also presents an essential package for palliative care in primary health care, which is heavy on physical and psychosocial support, but weak on social and spiritual recommendations for comprehensive palliative care. And we also know from the guideline that it only recommended 3 to 6 hours of training, which is totally stripped back for community healthcare workers. It recommended 1-day training for nurses, which is different from the training that is provided for physicians. And these nurses and community healthcare workers seem to be the backbone of primary healthcare delivery in countries like Nigeria. So this training might not be enough for them. Also, another recommendation from the WHO guideline was that it highlighted the need for research to measure the value, the acceptability, the effectiveness of palliative care within primary healthcare, and to explore the knowledge and attitude of healthcare providers about providing palliative care at this level. And the last thing that we noticed is that it provided a lot of recommendations without a scalable intervention or a program theory to sort of really help us to understand how to do this. And it also assumes that patients with serious serious illnesses in low and middle income countries are going to come to primary health care. From previous research, we have known that patients in Nigeria, for example, will skip going to primary health care to go to a tertiary healthcare facility for conditions that can be treated within primary healthcare, because the primary healthcare simply does not serve as a gatekeeping mechanism for the higher levels of care, and this overburdens the higher levels of care. So we designed our study, which had 6 major objectives, and was designed within the context of the Medical Research Council framework for developing complex interventions. So our objectives are in the slide. I'm not going to read through everything, but majorly it is to develop and also to test the feasibility of this complex intervention to deliver palliative care within primary health care. So this is the Medical Research Council framework for developing complex interventions, and it's sort of as 4 stages revolving around some core elements that are very important. The stage 1 is to either identify an intervention that has already been developed and try to adapt it to your context, or to develop the intervention by clarifying the theory of the problem, and also to test the feasibility of the intervention, then to evaluate the intervention, and then implement the intervention more broadly. But while doing this, you focus on the core elements, which are context, theory, and also stakeholder engagement, to ensure that the intervention addresses what it needs to address, and it's feasible, it's acceptable, it's appropriate, and it's effective. So, but then we ran into a problem. How do we clarify the theory of the problem? We know that it is difficult to identify patients with palliative care needs within primary health care, even in high income countries. And available tools are based on prognostication, which is inaccurate and may not align with the cultural beliefs in this part of the world. And some tools also use clinical indicators that are impractical to use within primary healthcare in low and middle income countries. Therefore, we need a needs-based approach, which has been recommended and proposed by researchers. And this needs-based approach then requires us to look through the evidence to understand how do we identify patients based on their palliative care needs to be able to deliver palliative care for them. Yet, as palliative care evolved in high-income Western countries, the understanding of what constitutes palliative care needs in different domains and how to operationalize this definition to capture multidimensional needs remain weak and vary. So our earlier concept analysis revealed that terms like symptom burden was being used to represent palliative care needs. And if you look at the quote there, what is in a name, that which we call by a rose, we call a rose by any other name would smell as sweet, but that is not always the case. If you call a palliative care need symptom burden, then the things that can be measured as symptoms are maybe pain, the physical symptoms, the psychological symptoms. But when it comes to the social burden, the social distress, the spiritual distress that accompany these serious illnesses, they are not covered adequately by using the term symptom burden. So we needed to understand what constitutes a palliative care need in people with serious illnesses across Africa. And in order to do that, we reviewed 150 papers to really understand what constitutes a need and to identify an African-specific palliative care needs framework to provide holistic and nuanced understanding of palliative care needs and support comprehensive assessment as well. So if you scan the QR code, you'll be able to read that paper that was published. So after doing that, the next phase was to then develop our intervention. To develop our intervention, the first thing we did is to engage broadly with patients, with primary healthcare providers, and with families. So we conducted this study. We interviewed 21 patients who had cancer, category 3 or 4, heart failure, MDR, that is multi-drug resistance, and extensively drug resistant tuberculosis, and patients who have suffered from a stroke and still had some neurologic deficits. So we interviewed 15 family caregivers, and I also interviewed 12 primary healthcare providers, including 3 doctors, 7 nurses, 2 community healthcare workers from 3 primary healthcare facilities in Nigeria. So we wanted to know uh, patients and families' experiences of using primary healthcare while living with serious illnesses, healthcare providers' experiences of supporting these patients, and participants' understanding of palliative care needs and their priorities and expectation for this intervention to provide palliative care within primary healthcare. And we analyzed our interviews by thematic analysis. So here are the themes from our study. Patients are burdened by serious health-related suffering, and they are desperate for whatever is available, but they are also not sure about the quality and the training of primary healthcare providers. And there is a poor perception generally of primary healthcare ability and function to be able to manage their conditions. Also, in terms of healthcare providers have an attitude towards patients with serious illness, which meant they refer at sight when they see a patient with serious illness. They have minimal engagement with them. They feel that primary health care is only for minor ailments and acute conditions and to provide first aid. And they also see their role as maternal and child health services and not engaging with patients with serious illnesses. So they also acknowledge that there is an interprofessional distrust within the system, which I'm going to speak to later. And when proved further, they acknowledge that they already do some of these tasks or interventions that are required to provide palliative care in some form or shape in the care that they provide. So these are some of the quotes from our interviews. And this really highlights from patients and families' perspective the sheer burden of suffering that they have in between appointments at the tertiary healthcare facilities with specialist disease managers, specialist disease physicians. So and they had inadequate support. So the lack of basic information about their conditions was also highlighted, and this adds another layer that amplifies the suffering that patients go through. And there is also a hesitation around whether palliative care providers within primary health care will be consistent, and that care will be coordinated with the specialist disease-focused care that they receive at the tertiary healthcare facilities. And they also mentioned the need to capitalize on the existing relationships and bonds that they already have in using primary healthcare. So from the perspectives of the healthcare providers, these quotes really bring out the distrust, the cycle of distrust, I call it, within the primary healthcare in Nigeria. Patients do not trust the standard and the quality of care that primary healthcare providers will offer within primary healthcare. Primary healthcare providers, some categories of them, especially doctors and nurses, do not trust the community healthcare workers to be able to work within their competence to provide care for this type of patients. And also tertiary facilities do not trust the primary healthcare providers to be able to support the patients adequately. So there is also primary healthcare providers do not see themselves as appropriate for the management of serious illnesses. And this created a question of how do we address all this and develop the intervention. And then the plan was meant to work and the plan was working, but then COVID happened and the plan stopped working. Then supermarkets ran out of tissue. And then you have this kind of post on Twitter, and I had to import tissue for my wife to Canada from Nigeria, catching the last flight out of Nigeria on March 27, 2020, while interviewing patients. And the airport was shut down until September 2020. So that changed our overall plan. And everything became virtual, and we had to pivot. So our intervention development, which was planned to be developed with multiple stakeholders, we had to uh, refine the methods and develop the intervention online. So we conducted 2 theory of change workshops online to develop the program theory of change, and the image you can see, the figure, is the program theory of change to understand the mechanism of impact within this framework. The first workshop included 19 primary healthcare providers, which was online. And the second workshop engaged with 9 specialist palliative care providers at a referral hospital also. So based on our analysis, we developed this theory of change, which in a nutshell is really talking about this complex diagram is really talking about if we have all the prerequisites and we are able to train primary healthcare providers and we have the right referral linkages to specialist palliative care and community NGOs, and providers can deliver the intervention as intended, and patients and families can receive the intervention as intended for the required duration, then patients and families will feel engaged, their needs will be prioritized, they will feel empowered, their symptoms will be relieved, their worries will be allayed, and they will feel supported with their financial burdens, and they will feel that their spiritual values are affirmed. And that is how we are going to achieve the outcomes and impact that this intervention aims to achieve. And so our intervention training, we needed to develop that. But based on our analysis of the WHO recommendations, we know that the intervention, and based on the work from the qualitative study and the data that we got, we know that the intervention cannot be um, a single professional focused intervention. So we know we have to take an interprofessional, multidisciplinary approach to developing and delivering this training. Also, there were uncertainties that were identified within our theory of change. And those uncertainties, we have about 10 of them, but in essence, they boil down to 3 things. Will patients come to the primary healthcare for this intervention? Will healthcare providers' knowledge, attitude, confidence, and skills to provide palliative care within primary healthcare improve? And will the necessary systemic supports for the intervention be available, such as the referral systems, the staff that are needed, and all that? So I know my time is rounding up. So the feasibility testing. So after we developed the program theory, we needed to test the feasibility. But with the reality of COVID on ground, our feasibility, we could not test the feasibility in terms of the delivery. We used the Kirkpatrick's model for evaluating educational outcomes. And the model is simply has 2 sides really in terms of evaluating the training outcomes and evaluating the delivery outcome after the training and the application of the training. So we couldn't do the delivery aspect because of COVID, and facility managers from the primary healthcare facilities were not ready to take the risk of having patients with serious illnesses come to their facilities for the intervention. So we stopped at the training. So due to the strong staffing issues that we also identified, we decided to stop at the training. So our feasibility study really focused on a single arm, non-controlled, non-randomized pre-test, post-test study design with a focus group with attendees of the training. So we have about 13 participants, but 12 were retained in the end. The training was a 24 hours training delivered over 3 days. And the training was tested in 3 primary healthcare facilities located in 3 municipalities in Nigeria, which is, which is home to a population of about 750,000 people. So we tested recruitment, we tested retention, appropriateness, acceptability and feasibility of the intervention. We tested the knowledge and attitude of the healthcare providers and also their confidence to be able to deliver palliative care intervention within primary healthcare. So this was the acceptability, feasibility, and appropriateness figure, which showed that the training was deemed to be acceptable, to be feasible, to be appropriate, and to be relevant for the participants. From our focus group discussion, these are some of the quotes we got, which really involves three things: that understanding the need to provide support for patients with serious illnesses at this level, rather than immediate referral, is important. And also considering that the training is relevant to the work within primary health care was also important. And the participants were also able to reflect on their own mortality and their own journey to compel a state of empathy. And I will still talk about that within the findings. So in terms of knowledge, the participants' knowledge of palliative care increased across board. And the figure also suggests that there were reductions in omitted questions when you compare the pre-knowledge test to the post-knowledge test. And that also suggests improved knowledge. So these are some of the quotes from relevant to the knowledge. And this improvement in knowledge was really highlighted in the clarity around the word palliative. So there was a lot of confusion around what palliative care is before the training, even amongst healthcare workers. So that was something that was really important. During COVID, there were supports that were distributed that was called palliative in quotes across the country. So using the word palliative really created some confusion, but now they understood palliative care more. There was also a shift in perspective from curative to holistic care as well, to understand the multidimensional nature of the human experience. So this is from the confidence. The confidence also improved dramatically, as you can see. And these are some quotes in terms of the confidence. And their increased confidence is really founded on demystifying the complexity of care for patients with serious illnesses and also demystifying the dying process. But the story was not the same for attitudes. And we know that in training, for any new intervention, really changing attitudes is what matters. But the attitudes increased in 5 participants, decreased in 6, and remained the same in 1. Overall, the attitudes appear to also become more polarized. And this might be due to 4 things. 1, some may not have understood properly before in the first test and were unsure, but after the training, the improved knowledge highlighted their real attitudes to some of the concepts. For example, question 24 of the attitude test, there are times when death is welcomed by the person dying. This was really something that highlighted the significant shift in attitudes towards polarization there. And also there was controversial and inconsistent policies within the country, which we had to include inside the training. For example, nurses and doctors were able to, doctors were given the permission by the National Policy on Drug Control to prescribe morphine at the primary health care level, and community health officers and community health extension workers are also given that permission, but nurses were not given the permission to prescribe. So that created some problems which the nurses highlighted during the training. So also number 3, the general attitudes to issues surrounding death, spirituality, and morphine use were also highlighted in terms of the patterns we saw in the attitudes. And there might also be, and this also might be a problem with the self-developed and untested measure that was used in measuring attitudes as well. So this is also the attitudes. And these are the quotes in terms of the attitudes. And the first quote really emphasizes how the intervention training strongly evokes reflection on own mortality, own journey, and how this can strengthen attitudinal change in providers. And this has been identified in other studies as well. And also a background context is that many of the participants in the training, their age range was between 46 and 52. And we know that the life expectancy in Nigeria as of today is about 63. So many of them are able to reflect on where they will be in the next few years, and knowing that patients that they refer without engaging within primary health care end up with those added burden, and them thinking about their own journey as well. The second quote highlights the lingering primary providers' fears and concerns about the public perception of their competency in a society where the literal translation for hospital or clinic is the house of cure. And as they try to reconcile their role as harbingers of cure with supporting patients to die, even if that is dying well, they still felt conflicted that they will be considered incompetent when they are doing that. So what did we learn? What did we contribute overall? It is difficult to recruit community healthcare workers for training. We found that primary healthcare providers are generally engaged with the training, and that uh, uh, really is based on their own reflection on their journey and their mortality, to be able to force a state of empathy for patients with serious illness. And also the training contents will need further refining to ensure that attitudes improve as well as knowledge, especially in the areas of morphine prescription, the ethical obligation for palliative care within primary health care, attitudes to death and dying more generally. And also we were able to contribute an understanding and assessment of palliative care needs. We were able to contribute data to improve the WHO recommendations for integrating palliative care within primary health care. And for further research, I've highlighted some areas that we think further research need to focus on. I think one other issue that really came up in the study was how to certify a patient dead when there is no doctor. In Nigeria, the law only allows the doctor to certify a patient dead. So if you are going to provide primary palliative care and some primary health care do not have doctors available, then how do we manage that? So there's a need for those local policies as well to support that. So I want to acknowledge my supervisory team, Professor Richard Adden, the project advisory team as well, and my local collaborators in Nigeria, Professor Oladayo Shoyinwo, and the Center for Palliative Care Nigeria at the University of Ibadan, University College Hospital Ibadan. And also to all my colleagues within the Palliative Care Network for the flexibility to allow me to do this presentation. Thank you.
Fantastic. Thank you so much. I'm not sure if, can you hear me okay?
Yes, yes.
Okay, yeah, just my visual is a little choppy. Wonderful. What a complex issue and fabulous research. So thank you for sharing. I do have some questions, but I'm going to hold my questions because I would love to open it up to our audience to ask questions, comments, just a really timely and important topic. So, okay, I'll stop speaking. And who would like to go first? You can turn on your camera microphone if you want to put up your hand as we go through. I'll call out your name. Just give everyone a moment there to think. Sarah, go ahead.
Great job, Dio. That was excellent. Yes, a very, very complex issue for sure. And makes me think about a lot of things, but I may have missed it. I had to step out at one point, but I'm curious, the training intervention itself, what specifically did you use to develop the training intervention, Dio? And apologies if you spoke about that and I missed it.
Yes, so the training intervention was really based on a training that had been developed earlier, but adapted into our own context based on the findings that we've done, based on our review of the WHO recommendations, and based on based on our qualitative data, we identified that there is a cycle of distrust. So there is need to bring everybody together in a multidisciplinary way. So we needed a training that will focus on the different competencies, the doctors, the nurses, the community health extension workers. And also we looked at the patients and their expectations based on our qualitative data as well to really adapt that training. And also we looked at the process of providing care within primary health care in Nigeria to really ensure that that process is engaged within the training and how we deliver that. And we looked at local policies like the National Drug Control Policy, the National Palliative Care Policy, the standards and interprofessional for the different professionals that were involved. So we developed we adapted the training that was already in existence from the World Hospice Palliative Care Alliance, WHPCA.
Thank you. That's helpful. Great.
Great. Anyone else? Go ahead. I see Lisa.
Hi, Megan. Not so much a question, but a comment and a little expression of gratitude to have Dio join our palliative care network here in Nova Scotia. Because although not in Nigeria, Nova Scotia faces so many similarities in the integration of a palliative approach to care that I feel that Nova Scotia truly is going to benefit, Dio, from all of the research that you've done. I already have like 10 side questions about different issues that you've highlighted. I had read your article, but must say, hearing the summary in person is virtually in person is way more dynamic. Thank you.
Yeah, thank you. Thank you, Lisa.
Great. If there's anyone else, jump on in. While people are thinking, if I can ask a question, sort of a little comment and question. So a number of us had done some research in Tanzania a number of years ago, but it was on postpartum care, but similar issues in that there were health human workforce issues. So with nurses and doctors, they did the postpartum care usually at the clinic, but really recognizing there needed to be something more larger in the community. So it was the community health workers who were really doing a lot of the work in the homes. However, that relationship, there was concern that the community health workers weren't trained with, the expertise that the nurses, they could identify and assess in a certain way. So all of that. So I love what you're doing and sort of bringing all of those people together. So I hear you talking about interprofessional, which is so important. And even in Nova Scotia, we used to have community home visitors work with public health nurses going into the home, and that was with sort of high-risk populations. I don't know what's going on there now, but globally, the issues of community home visitors and workers and interprofessional and even beyond nurses and doctors. As Lisa said, I mean, we all need to learn so much about how it can work, but also how people get together. So just hearing you talk about the attitudes and working. So I just want to hear a little bit more about the time together. And I know you did, sort of the outcome and how people were feeling, but just a little bit more maybe from the qualitative, like what are people saying and feeling, and can you really work together? And are there other people that might need to be brought in?
Yes, thank you very much for that question. And it's interesting. At the beginning, it was chaotic because because there was somebody that attended the training, a nurse manager who felt at the beginning just stood up and said, I don't think this is appropriate. We know patients with serious illnesses needs to be handled with care. We've had issues with community healthcare providers, community health officers before, and I don't think we should be broadening this to include them. We should have only nurses and doctors doing this. So I just welcomed the comments, and I already saw the faces of the community healthcare workers that were present, and and how that made them feel. But then I had to manage that in terms of how the policies that are on ground and what those policies have stated. And one of the things I told her is I definitely agree with her based on what she said. And even the WHO recommendations, the recommendation for training community health workers is different. But from our data, from the qualitative data, we know that there is distrust. You don't trust these people to be able to give care the way you want them to give care. So if they don't have access to the right training to be able to do that, then how do you expect them to improve on what they are going to do? And also the policies in the country already gives them a lot of power to be able to do a lot of things anyway. And if they don't have the training to do those things, how do they do them effectively? And so it's important that we bring everybody together in a way that ensures teamwork. So teamwork and team building was one of the main topics that we added into the training as part of the adapting, to let them see that palliative care is something that is a team approach to provide. And the doctors will have their own work, the nurses will have their own work, the community health workers will have their own work, and delineating the roles and responsibilities was very, very important within the training as well. So those were the ways we were able to manage that. Yep.
Yeah, no, I love hearing that. Thank you. And just, yeah, how do you bring training together and people together when we know those attitudes exist and continue to? But yeah, thank you. That's great.
Thank you.
Yeah. Other people, comments, questions? All right. Maybe was there anything else that you wanted to share with us, Deo?
Um, as regards the project, I think we are continuing to look at our data. The last data, the pieces around the knowledge, attitudes, and confidence is not yet published. Those are the ones we'll be publishing. And we are also looking at it from a consolidated framework for implementation research perspective to really understand what barriers and facilitators were in existence within that context, and also more broadly during my postdoc working across 6 countries in Africa, looking at primary palliative care. We wanted to really understand how do we understand this context to be able to implement this procedure, this intervention as well. But apart from that, I think from a palliative care network Nova Scotia health perspective, a part of the mandates of the network is in terms of research and quality improvement, and really being able to bring together researchers from nursing, from medicine in an interprofessional way to look at palliative care issues in Nova Scotia will be important. As we engage with our frontline workers, we are hearing some issues that raise a lot of research questions, and we think there are opportunities there as we build our research strategy as a network more broadly.
Yeah, that was going to be my next question because, yeah, bringing you and your expertise and what are you going to do here in Nova Scotia. So thank you for that. Because I know at Dalhousie University, we have a very strong focus on interprofessional education, as you know, and I'm just talking about within our Faculty of Health, Medicine, Dentistry. So yeah, really look forward to working with you and all of your other colleagues who are there.
Yes, definitely. And
Yeah.
I should acknowledge the presence of my colleagues, Lindsay, Sarah, Lisa, Matt. Thank you so much for coming.
Yeah, thank you so much. It's great. We had a good turnout today on well, looks like it's a snowy day. Any last questions or comments from people online? Give you a second to press that unmute button. Great. Well, that was a fulsome presentation and discussion. Thrilled to have you on board today. Thank you so much.
Thank you very much. Thank you very much.
Thanks, everyone. Yay.
Thank you.
And yeah, so and it's recorded, so people will be watching this afterwards.
All right. All right. Thank you very much, Dr. Astin. Really appreciate the opportunity.
Great. Thank you.